Richard Hallinan here. Everybody else has got their various qualifications on the introductory slide. I'm just an addiction doctor. Perhaps in this role, though, I could be also claiming the title of rat bag at large, because I will be perhaps a little provocative in some of this. We have our two pharmacists and researchers in our field, Ailey Langford and Susie Nelson, to give a presentation later. The presentation of a paper which actually gave me the courage for us to present this seminar this evening, it being such a fraught area. Just noting as Jenny James, who works with us as a GP VMO in southwestern Sydney, will also present a case where we're going to have a couple of cases. Jenny's case, I believe, will be one of the not so easy side of deprescribing. The other case was going to be on a case of anguish with deprescribing, and in the end, I'm not going to present it because it would be too painful to do so. Paul Haber, if he'd been here, probably would have contributed a similar case. So as discussants, Simon Holliday and Sharon Reid, both GPs, Simon a fellow at the Chapter of Addiction Medicine and Rural and Remote Medicine, both contributed to the guideline which Ailey and Suzanne will present. Jenny James I've already mentioned, and Hester Wilson, of course, always good for an opinion, insights, and also, but like Simon Holliday, a dual fellow, addiction medicine and general practice. So here's the term opioid deprescribing, which I wrote in the flyer as part of an increasing push against long-term prescribing of opioids in recognition of the adverse effects, overdose, dependence, the so-called opioid epidemic, and the lack of evidence of long-term benefit. Now, Ailey wanted to express that somewhat differently, and she will do so. But I have to say that those words, the pushing against long-term prescribing, sort of reflect the way that I am perceiving this from where I sit and where I think a lot of doctors also perceive it. Feeling a bit squeezed, as they feel under pressure, and patients complaining also about being left without pain medication as this move takes place. And here are just a couple of the headlines that I'm sure you'll all seen. This one was from the College of GPs, News GP. It's a missive that comes out every now and again, very critical of an intimidating, unpleasant warning letter that was sent in 2018 to the top 20% opioid prescribers in the country, saying basically, guys, you know, either pull your socks up or be careful what you're doing. People took great umbrage at that. The Federal Department of Health actually studied it, and here you can see some data comparing in the blue the people who received that letter, their prescribing rates for opioids before and after the letter, the intervention, and in green, prescribers who didn't receive such a letter but were prescribing similar amounts. And the conclusion was, this works. Well, it certainly has an impact. Whether it's a good impact or a significant impact is the question. There's been impacts on patients too, and Pain Australia, advocacy body of very long standing, did a survey which showed some of the concerns that are really widespread on the people that were reached by that survey. There's one paper I wanted to mention from some colleagues in the United States. It's from 2020, and they were taking stock of deprescribing at that point, noting how it had begun in the United States, that the downward trend had actually begun in 2011, but by 2019, prescribing had declined across the country by 37%, and that this had really accelerated after the CDC, the Centers for Disease Control and Prevention, brought in a guideline for the use of opioids in chronic non-cancer pain, which advocated the avoidance of opioids in chronic non-cancer pain and in some measure deprescribing. As they note here, by 2019 it was very evident that there were a lot of ill effects resulting from this, and I'm sure Ailey and Suzanne will go into this in more detail. So by 2019 already the CDC had claimed that its guidance had been misapplied, as they write here very eloquently. prescribing once had rocketed ahead of the supporting science. Now deprescribing is often mandated and carried out in ways that lacked evidentiary support. And I could probably just stop the introduction there. But I wanted to just lay out a few of the pressures that are on prescribers to deprescribe. And there are professional guidelines, and you see a raft of them there, all remarkably similar. Recently changed TGA regulation around opioids, and that's actually about the labeling or the indications for medications. We're all au fait with SafeScript now, and to say that when those warnings come up with the exclamation marks, that doesn't have an effect on prescribers, I think would be naive. Even if the warning is actually purely generated by algorithm. Now, sometimes where there is a New South Wales PRU, Pharmaceutical Regulatory Authority, conditions, regulatory unit, it should say, I beg your pardon, if there is an authority for the prescription of opioids, there will be conditions on that, and that may also affect and put a pressure on prescribers. Then, of course, there are Medicare restrictions. Most people will be aware that there was a requirement introduced for a second opinion for continuation of opioids longer than 12 months in chronic non-cancer pain. You could add to that perhaps concerns about indemnity assurance, only just popping into the occasional Avant newsletter at the moment. But if we look to America, where the opioid epidemic was driven by doctors fearing the loss of their livelihoods and their licenses if they didn't prescribe opioids for people and being sued for enormous amounts of money. And now the opposite happening, that people are losing their livelihoods and their licenses for continuing to prescribe against certain guidelines. The ground rules of regulation, just to briefly mention, let's not forget that in New South Wales, the New South Wales Medicines, Poisons, Therapeutic Goods Act is the legal basis of a lot of how we prescribe and how we do those things. And the Health Secretary of the Ministry of Health, as I understand it, has the ultimate responsibility for enacting much of what is laid out in the legislation. And in particular, our Pharmaceutical Regulatory Unit issues authorities for some people for opioids, S8s, and as you all know, the opioid treatment program. At the other end, Medicare authorities are quite a different thing. They're just an authority for a medication subsidy and nothing else. You don't want to make false claims when you apply for an authority of that kind, but the legality of the prescribing is not affected. It's surprising how often you hear from doctors who say, well, I have an authority, I phoned Canberra and everything, and they really don't know that they're prescribing illegally something that requires a New South Wales Health Authority. Then, of course, there is the TGA, which allows goods to be registered for use, for supply, for prescription in Australia. And in doing so, there is an approved indication known loosely as labelling. And aside from, you can prescribe outside an approved indication. The TGA won't stop you from doing it, but you may expose yourself to peril or criticism if you do so. For instance, prescribing quetiapine for chilblains might be frowned upon and could expose you to action. There are some authorities that can be granted under the Special Access Scheme for non-registered products, but they're the authorities that I wanted to mention here so that we don't confuse them. In New South Wales, an authority from the Ministry of Health is required to prescribe or supply a drug of addiction, and that includes all of our S8s, for a drug-dependent person. We'll define on the next slide. But also for a non-drug dependent person who's prescribed the opioids for more than 2 months, the so-called 2-month rule. Now, the 2-month rule used to cover all opioids, except the low-potency opioids like codeine, so all S8 opioids. But about 20 or 25 years ago, morphine, oxycodone, and transdermal formulations were exempted from the 2-month rule for the simple reason that doctors simply couldn't keep up with making these applications. The paperwork was so massive, and so it was more observed in the breach than the observance. That means, however, that still for any injectable opioid, any transmucosal opioid, for buprenorphine, hydromorphine, and methadone, you do need an authority. So who's a dependent person? Under the legislation, even though this is wording from 1966, it seems to be still the current definition, a drug-dependent person is a person who has an overpowering desire for the continued administration of the drug in question. Now, that is not the same as ICD-11. So what should we prefer? What does PRU consider is a dependent person? How do we navigate our way through that? Do we use DSM-5 criteria? Do we say that any opioid use disorder or only a severe one is somehow dependent? Or may this refer just to physiological dependence, a person who just has tolerance and may have withdrawal, but nothing else, which would not make them dependent in ICD terms, and I suggest wouldn't meet the definition of drug-dependent person. But these things are fraught, and they do come up, and they cause uncertainty and sometimes conflict. So the TGA indications for opioids did change after a lot of consultation about the concerns for opioids, and they made clear that immediate release opioids are only for short-term management of severe pain. So that is the labeling now. Modified release products should only be used when other analgesics can't be used or are ineffective, when the pain is opioid responsive, and when the patient requires daily continuous long-term treatment. So you can't use those just every now and again. You can't use them for PRN pain relief according to the TGA. If you do so, you're doing it off-label. Now, the Faculty of Pain Medicine is one of the College of Anaesthetists is one of the bodies that's put out guidelines like those of the GPs and like all the other bodies that I mentioned, and they really are all very similar. They agreed, well, they noted the TGA remark that modified release opioids are not to be used in chronic non-cancer pain other than exceptional circumstances, and they defined them as you can see there. So the pain has to be opiate responsive, other treatments have to have failed or be contraindicated, and so on. Short-acting opioids, again, should only be used to suss out whether a person is likely to have pain that's responsive to opioids. And they note in particular that the suggestion that they are particularly risky for the development of tolerance and positive reinforcement, something that I would actually question. They also specified treatment goals, which is very helpful. And I'm not going to show you the slide of the treatment goals that are appropriate for a trial of opioids. But they point out that if the goals are met, then you should consider reducing the dose to the lowest dose that is associated with the benefit. And this may not be zero. Well, that's good to hear. If the opioid trial goals are not met, they've got two rough rules of thumb for how you might reduce, whether weekly or monthly, and I suggest there's probably almost no evidence for either of those other than the feeling around the room. Now, if you do get an authority from the PRU to prescribe an opioid for chronic pain, that authority may not be shared with anybody, so I can't share one with you here, but I can tell you that commonly the prescriber is informed that they have to inform the patient that there is a risk of accidental overdose and death. They have to note that opioids become less effective over time. Is that always true? But that's there in the authority. And that pain may worsen owing to opioid-induced hyperalgesia. Well, that may happen, yes. The oral equivalent morphine dose should be no more than 60 milligrams, and it should not be continued for more than 90 days without not just a pain specialist opinion, but a multidisciplinary specialist pain support. So you can't just send them to your local pain specialist. It has to be a multidisciplinary team, according to these letters, some of which I've seen. These are not the exact words. I'm not replicating or providing these to anybody else other than my transliteration of them. Also, they repeat the now accepted truism that evidence does not support the long-term effectiveness of opioids in this indication. But they may be used short-term, and after that, the standard approach is gradual opioid withdrawal towards cessation. So, not like the pain faculty, who notes the dose may not be zero, the standard is to reduce towards zero. So I'm left with two challenges and two questions. One, the CDC itself said very early in a groundbreaking recommendation that actually when you start opioid therapy, you should prescribe immediate release opioids rather than extended release opioids to avoid around the clock opioids. This does not seem to have made its way into any guidance in Australia. I have to mention it again. Evidence does not support the long-term use of chronic opioids. Therefore, opioids don't work for chronic pain, because that's the sentence that I hear very often. Opioids don't work for chronic pain, which I think is an absurdity. The mistake here intellectually is to mistake or to muddle the chronicity of the opioids and the chronicity of the pain. Chronic opioids are probably not good for chronic pain, but opioids in chronic pain can still be effective. So the questions that arise that keep coming up to me in my talking with doctors who are afraid to prescribe, a lot of them, who prefer to believe their N equals 1 patient experience, particularly for people who've been on opioids for quite some time. Are we throwing the baby out with the bathwater? And above all, what do we do about the legacy patient? And thankfully, I can escape from this now, or attempt to stop share and pass you over to Susie and Ailey, who have done a great job with their colleagues to come up with some answers to these questions.
Thank you, Richard. I think Susie is going to start off first. Is that correct? Beautiful.
Just attempting to navigate Zoom. Can people see what looks like the right slide? I'm going to give a very short introduction because I really think Ailey should have the majority of the time. The deprescribing work was really the centre of her PhD work. And so I'm just going to give a few short minutes to talk about, I guess, what could possibly go wrong. I do also want to acknowledge the traditional owners of the lands on which I work and live. So I'm on the land of the Boonwurrung and Boonwurrung land people of the Kulin Nation, and I pay my respect to their elders past and present. So I think that if you haven't seen this graph at some point in the past few years, I don't know where you've been, but I just wanted to really just kind of revisit this to highlight a couple of points. Really, one of the key points that Richard has just mentioned is that there was a large reduction, a 37% reduction in opioid prescribing that came about as a result of the various guidelines and interventions in the US. That started about, if you can see, around here in the graph, actually. And I think one point that I wanted to highlight is we did not see a 37% reduction. We saw a very flat line in prescription opioid deaths following that large reduction in prescription opioid prescribing in the United States. And so it's a little bit of a tale of caution that we know there's a very strong correlation between increased opioid prescribing and increased harm, but it actually hasn't been demonstrated that as you reduce opioid prescribing, that you reduce opioid harm in the same sort of tightly correlated way. And so I guess that is a word of caution. And what was seen in the US, and we're obviously not the US, was this very large increase in other opioid use and harm. And a lot of that has been attributed to kind of various guidelines and interventions that were aimed at really quite aggressively reducing opioid prescribing. I know as well that Richard mentioned these CDC guidelines. There was actually a consensus panel report that was published more recently, sort of reflecting on those guidelines, and that panel identified that those guidelines, when they were implemented, had a number of challenges, including application of dose ceilings that were fairly arbitrary, applications of duration guidance. I've underlined here failure to appreciate the importance of patient involvement in decisions to taper or discontinue opioids, and a range of other barriers, and also the misapplication or overinterpretation of these guidelines as well. And so I think this issue, particularly around the role of the patient, is something that came up very heavily and was constantly in our minds when we were working through the guidelines, and I'm sure that Ailey will talk to that. I did just want to talk about some of the research that has come out in the US about tapering people off opioids, because this is really where the concerns start to set in. There's been different studies of varying rigor, but all with very consistent results that when people's chronic opioid therapy is ceased, their risks actually don't seem to cease. And so those people who were ceased on their opioids actually had an increased risk of death and overdose death compared to those who were maintained on their opioids. We've also seen different studies finding associations between stopping opioids and suicide and death in US veterans, and also studies showing clear associations between tapering and mental health crisis with people on long-term opioids. So it isn't as simple as we might think in terms of tapering, and I think that that's probably one of the reasons that many people in the room are a little nervous to start this conversation around deprescribing. I have mentioned around a lot of US evidence, but I did also just want to highlight two studies that come from Australia that suggest that these are not limited to the US, that we have already seen studies with people on prescription opioids in Australia that highlight that there are patients who are having really challenging experiences. And these are two quotes from this study of patients who were sort of reflecting sort of suicidal thoughts and concerns around a lack of access to their opioids. So this is local data. And also another study from a chronic pain cohort where it was actually shown that 1/3 of the patients in this chronic pain cohort reported challenges in either accessing their opioids or having their opioid medicines involuntarily reduced. And this was back in 2018 and 19, I think these data were from. So we were already seeing concerns that were affecting patients, quite some time ago. So I think this really does set the scene for, I guess, the level of caution and care and patient involvement that was involved in the producing of the guidelines that Ailey is going to talk to you about now. So I will hand over to her. You're still on mute, Ailey.
We're all having Zoom struggles today.
But your slides are perfect.
Excellent. Thank you, Susie, for that introduction. My name is Ailey, and I'm currently a postdoctoral research fellow at Monash University in the Centre for Medicine Use and Safety. But I also have the University of Sydney's logo up on here because the program of work that I'm going to speak to today was conducted as part of my PhD at the University of Sydney, which I finished up at the beginning of this year. So I think both Richard and Susie have spoken much about the CDC guidelines in the US and how perhaps the misapplication or misinterpretation of these guidelines led to unintended harms. But I think maybe one of the positive things that came out of it for us was the realization that with an absence of clear and actionable recommendations or guidance to clinicians about when and how to reduce or cease opioid medications, there is this potential for harm, and really spoke to our research team's need to develop clear and evidence-based guidance in this space. And I think it is interesting that since this program of work has continued, the CDC has released a 2022 version of the guideline that does have some more consideration about the concept of opioid deprescribing compared to the original 2016 version. So deprescribing, Richard gave a definition of how he was interpreting deprescribing and the push towards deprescribing within Australia. I suppose more traditionally, when we think about deprescribing, it's often thought about in the context of older adults and looking at reducing polypharmacy and harms related to polypharmacy. And so to date, there has been evidence-based deprescribing guidelines developed for other medication classes, particularly from a group in Canada. But really looking at older adults, so medications such as proton pump inhibitors, benzodiazepines for insomnia, antipsychotics for people with behavioral and psychological symptoms of dementia. But in essence, the concept of deprescribing is really looking at how can we reduce medicines where the potential harms of therapy are deemed to outweigh the benefits. And it's really a complex area because these medications aren't necessarily harmful or beneficial in any sense. So it's really going to be something that has to be determined in the context of a particular individual, and that risk-benefit profile is going to change dependent on individual characteristics, but it's also likely going to change over time as people age, the pharmacokinetics and dynamics, how medications work, what other comorbidities people have is going to adapt. And so I think this really brings into light that this concept of deprescribing has to be individualized. There's not going to be any one-size-fits-all solution when deprescribing a medication. And this is something that we really thought was very integral for the concept of opioids, particularly when we've seen what other strategies have been implemented to try and standardize opioid use in terms of mandatory strategies like the TGA legislation and regulations that Richard spoke about earlier. Whereas I think deprescribing, obviously, and deprescribing guidance is going to be much more of a non-mandatory approach, but trying to give both patients and healthcare professionals the best evidence and advice based off the literature in terms of when and how we can go about doing this. So I just want to give a quick screenshot of the deprescribing guidelines out of the Canadian group, if anyone is interested in learning a little bit more about the existing guidelines. And then there's also one for cholinesterase inhibitors and memantine in people living with dementia, which was a collaboration between Emily Reeve from Australia as well as the Canadian group. So the opioid guideline was a little bit unique in the sense that it wasn't focused on older adults. And I think, as Richard and Susie have both highlighted, there's quite a few more complexities for this particular medication class, perhaps compared to some of the existing deprescribing guidelines. So one of the first steps that our guideline development group conducted to try and get this process happening was some qualitative studies with key stakeholders. So we began by speaking to healthcare professionals about what are the challenges of opioid deprescribing, but also what types of things would they require additional guidance on. And this was really to help us inform the scope and the content of the prospective guideline. And I just wanted to show this quick slide to say that there were a huge number of challenges related to opioid deprescribing, and we categorized these at multiple levels. So there was issues specific to the medication. This quote is saying that centrally acting drugs are more difficult to deprescribe than other types of medicines. So I think people gave examples of things like a PPI is much easier to deprescribe than an opioid. There were patient level characteristics that made opioid deprescribing perhaps more complex, whether that be that there's not really great alternative options to offer patients to treat pain conditions when suggesting deprescribing. There were prescriber level barriers. A lot of people sort of expressed this concept of clinical inertia. So if they'd been prescribing an opioid long-term for a patient, it was almost easier to continue that prescription than broach the topic of deprescribing with their patient, largely due to fears about disrupting therapeutic relationships. And then there was also health system challenges. A lot of GPs that we spoke to said they don't feel like they had the time within their limited appointment times to have these quite complex conversations, possibly about continuation or discontinuation of opioids, but also other health system challenges in terms of the disconnect between hospitals and community. So probably the classic example of someone post-surgically or post an acute pain episode in hospital might be discharged home on opioids, and then they may be continued if there's not clear communication about the intended duration of therapy, for instance. We also spoke to patients or consumers, people who were taking opioids for pain. And one thing I thought about when Richard was giving his introduction was that we often at the beginning thought there were sort of distinct groups. Like we wanted the guideline to be looking at people taking opioids for pain. And then this concept of people with an opioid use disorder is a distinct population. But I think most people here would realize that that's not the case. It's not black and white in terms of the clinical characteristics, and that there's a huge amount of overlap in terms of how patients may present. And I hope some of the case studies in the discussion later on touch on this. But specifically, we were recruiting people for this qualitative study who were taking opioids for pain. And we conducted a framework analysis using Bandura's social cognitive theory. And we mapped a lot of the findings from the participants to sort of three main themes: that there were behavioral, cognitive, and environmental factors that influenced people's willingness to trial deprescribing, as well as perhaps the success of opioid deprescribing. And I also thought Richard had some great headlines earlier on about people's fears about not being able to access opioids, and that was also reflected in the qualitative studies that Susie showed on the screen before. But what I would say from the cohort of this study it was interesting to note that many people were interested in opioid deprescribing, in the sense that they were saying they don't necessarily want to be on these medications. It wasn't so much about the medication, it was about them and their pain. And so that was at the forefront of the responses of the consumers. Whereas when we talked to healthcare professionals, it was very medication focused, very deprescribing focused. So there was clear sort of differences in the priorities of these two groups. The patients were way more interested in having any kind of management strategy to help manage their pain. They didn't necessarily want to be on opioids and were happy to trial deprescribing if that was deemed appropriate, but they also were cautious that they needed something to manage their pain, and that was really integral to the success or the outcomes that they were interested in. So once we had maybe a better idea of the scope of the guideline, for instance, we saw that GPs would be our target audience because there was feedback from both consumers and healthcare professionals that general practice was probably the ideal setting for opioid deprescribing due to the continuity of the relationship between the patient and the prescriber, and the need for ongoing monitoring and support throughout the process. So once we'd done our qualitative studies, we assembled our multidisciplinary guideline development group. So we had 17 members on the group, and we had representatives from a range of different key stakeholders. So prescribers, general practitioners, pain specialists, addiction medicine specialists, consumers, pharmacists, nurses, physiotherapists. We also had a representative from NPS Medicine Wise, because at the time we thought they were a really important partner in terms of some of the implementation of the guideline and dissemination. NPS doesn't exist anymore, but it was still really great to have that representative on our group. And we generated 3 key clinical questions that we thought were really integral to answer, and they of course were informed by our qualitative work as well. So the first was, what are the benefits and harms of deprescribing opioids? So we looked at both dose reduction and cessation compared to continuation. We were really interested in this idea of how to deprescribe opioids. Was there an optimal approach? And I think Richard gave a bit of a spoiler earlier that a lot of the recommendations in other documents about how much to reduce by and how often perhaps aren't founded by literature. We actually found anecdotally that a lot of those documents cite each other in terms of saying what approach should be taken in terms of how to deprescribe. And we were also interested in which interventions are effective for deprescribing, particularly considering that it can be really difficult to reduce an opioid when there isn't another effective pain management option offered to a person. So we wanted to see were there any particular interventions that may be really effective to help people reduce their doses whilst maintaining their pain and function. So we utilized our qualitative work that I spoke about. We also had a range of evidence syntheses, predominantly an overview of systematic reviews because there is a huge amount of relevant literature in this space. And then we used what's called an evidence to decision framework to help generate our recommendations. And this framework basically allows you to contextualize the evidence from the literature in the context of the setting in which the guideline recommendations will be implemented. So considering things like the acceptability of the recommendations to end users, being both healthcare professionals and patients, but also what are the resource requirements for these recommendations? Do they have equity implications? Are they feasible to implement? And one example I like to give about how this evidence to decision framework can actually influence the recommendations is that we found that these multidisciplinary pain clinics were probably the most effective intervention to support people to reduce their opioid dose whilst maintaining important patient outcomes like pain, function, and quality of life. But the reality is in Australia at this point in time, these services are not readily accessible for all people, particularly if people are living in rural and remote areas. There can be additional costs or really long waiting times or extensive travel to try and access some of these services. So our guideline group felt that it would be really remiss of us to make a strong recommendation to say that if you're deprescribing opioids, you must engage with a multidisciplinary pain clinic because that just wasn't going to be feasible. So we ended up generating 11 recommendations, and I'll go through a few of them briefly, but I just wanted to say there's different categories or types of recommendations that can be made. So these green ones called recommendations, or they're sometimes called strong recommendations, are ones that can be applied generally across populations, whereas these conditional recommendations are ones where you really need to consider more the values, preferences, and goals of an individual when applying the guideline recommendation. And so, for instance, our recommendation about utilising multidisciplinary pain clinics or multimodal approaches was a conditional recommendation. The last group of recommendations down the bottom in the blue are called consensus recommendations. And this is a type of recommendation that the Australian National Health and Medical Research Council suggests you make when there's no clear evidence informing a recommendation, but the guideline group still feels like it's quite important to make a recommendation. And I've got a few examples of when we've employed those types of recommendations. So diving into some of the recommendations, we began with this consensus recommendation about suggesting for people to develop and implement a deprescribing plan at the point of opioid initiation. And I think our guideline group, although we didn't have any direct evidence to say that implementing a deprescribing plan led to better outcomes, it was kind of a common sense almost recommendation to say that if you are prescribing opioids, what is the duration of therapy? From some of our qualitative work, our end users said it was really important to set expectations about deprescribing at the point of initiation, really to prevent some of those disruptions to the therapeutic relationship later down the track if opioid deprescribing is being discussed. We then had a conditional recommendation about particular patient characteristics that may prompt opioid deprescribing or may make it seem like it may be more appropriate to trial deprescribing. And so they were things like if there's a lack of overall clinically meaningful improvement in pain, function, or quality of life, if there's a lack of progress towards meeting agreed therapeutic goals, or if people are experiencing significant opioid-related adverse effects in a range of domains. But we also thought it was really important in our guideline, not just to make recommendations about when it's possibly appropriate to deprescribe, but also when it is not appropriate to deprescribe. And you can see here that we have one of these consensus recommendations that I spoke of. You can imagine that there is no studies, no clinical trials comparing opioid continuation versus discontinuation at the end of life, because I don't think that would necessarily be the most ethical clinical trial to conduct. So we had no evidence to inform that, but our guideline group felt it was really important to still make a recommendation about not deprescribing in people nearing the end of life. Obviously, there's very different goals of care for people at that point. And I think a recommendation that's obviously going to be of interest to this group was about avoiding opioid deprescribing for people with a severe opioid use disorder. And that was because we had clear evidence that for this cohort, cessation of opioids can lead to much more significant harms, and that we should be employing evidence-based treatments in terms of transitioning to medication-assisted treatment, or we've included in there referral because recognizing that the target audience was general practitioners, not all general practitioners are trained or willing to engage in medication-assisted treatment of opioid use disorders. In terms of how to deprescribe, due to the lack of evidence, we didn't have a really specific directives about how the opioid deprescribing process should take place. And this was also informed by the literature because we found that in a lot of the successful studies where people had tapered their opioids, the approach had been tailored to meet the needs of that individual. So there wasn't a really rigid, structure reduced by 10% every week. It was really, suited or changed to suit the needs of the patients. And that's why we had two strong recommendations, even though they were based on low certainty evidence, to firstly say that if opioids are being deprescribed, they should be tapered gradually, warning against abrupt cessation of opioids due to the known harms that I think Susie highlighted a few integral studies earlier on. But yes, also making sure that the deprescribing plan is tailored to meet the needs of the patient. And in some of our qualitative work, for instance, we got feedback from people saying, I'd be happy to trial reducing my opioid dose that I take in the morning, but the one I take at night really helps me to sleep. And so for them, that might be really important. So there's no point saying that the approach that needs to be taken is one size fits all. We really wanted to reinforce the need that if opioid deprescribing is being implemented, that it is individualized. And then our recommendation 9 is just about ongoing monitoring and support for people who are engaging in opioid deprescribing. And I think it's also probably important to just flag here that under each recommendation in the full guideline, there is a range of what we call practice points, which have additional information about how the guideline recommendation may be implemented in practice, as well as linkages to important resources that may actually help enact the recommendation as well. So with the example of monitoring, linkage to validated and evidence-based tools that may help to monitor some of the domains that we're suggesting require monitoring. This last slide is about evidence-based interventions for opioid deprescribing, and I did flag earlier that multidisciplinary programs appeared to be the most effective based off our literature review, but recognizing some of the difficulties in access, we also wanted to include in this recommendation that multimodal approaches using multiple healthcare professionals may also be appropriate when someone may not have access to some of these multidisciplinary care settings. So once we generated our draft recommendations, we sent them and the full guideline out for public consultation feedback. And this was a really integral part of the guideline development process because we got a huge amount of feedback from organizations as well as individuals. And this really helped us to refine the guideline content. I think from memory, in one of our recommendations, we did have some information about particular dose thresholds that may increase the risk of harm. And there was a resounding feedback related to that recommendation that dose thresholds probably have the potential for more harm than good. And so, of course, we included the relevant evidence within the guideline, but we decided not to have any reference to dose thresholds or particular doses within the recommendations themselves. So I think that's just one example of how the really important feedback from our stakeholders helped to shape the guideline. And ultimately, I should have mentioned probably early on that we followed the processes of the Australian National Health and Medical Research Council in terms of guideline development. And we did get approval from them at the end of last year, which I think just reinforces that we really did take rigorous methodological steps to develop this guideline, which has received endorsement from some Australian and international organisations. I just want to flag that we did publish the guideline summary in the Medical Journal of Australia earlier this year, which is a summary of the recommendations and the guideline in a little bit more of a digestible format, if anyone does want to read more about it. And we're working now on looking at guideline implementation and have developed some resources. Firstly, a conversation guide, which came again out of the qualitative work saying that people really needed assistance with how to initiate and have conversations about opioid tapering, as well as an algorithm to try and sort of simplify and make some of the guideline information a little bit more digestible. So I just wanted to finish off by saying a huge thank you to everyone who was on the guideline development team, quite a few who are here today and you'll hear from. It was a huge undertaking, and as a PhD student myself, I learnt a lot from everyone and everyone who mentored me throughout this process. So huge thank you to everyone, particularly Carl, Daniela and Christine, who were my primary supervisors. And so I'll end it there and stop sharing my screen and hand back to you. Thank you.
Thank you, Aileen. I think we can open for some questions, and I'd encourage people to type them in the chat if you would. And we'll be calling on our special invitees perhaps to comment as well. I had a first up question, though. I seem to recall that the guideline, I wanted to pull it up in front of me to double check. It really does make clear that not everybody is suitable for deprescribing, and that if you embark on it and you review it as you go along, you would then evaluate the outcome of that. And the outcome may not be that you inexorably continue. It might be that you reach a certain point, realize that this is either not working or this is as good as it's going to get. Can you just talk us through that that side of things a little bit more?
Yes, definitely. And I think I tried to highlight it with some of the recommendations about when not to deprescribe, but 100%, I think we wanted, in terms of the scope of this guideline and the background information, to really highlight that it isn't a one-size-fits-all solution. Opioids obviously play a huge important role in pain management. And so we didn't want this document to be misapplied or misused, or to suggest that everyone should be deprescribed from opioids. And similarly, in terms of some of those practice points that I mentioned that link to the guideline recommendations, we have really clear statements about monitoring and if trying deprescribing. Again, as you mentioned before, that zero might not be the end goal. A dose reduction may be a really positive outcome, or that it's not a one-way trajectory. People may need to increase dose over time, depending on how that monitoring and how that process is going. So yes, I would agree with you, Richard. I think that's something we really wanted to say within the guideline, that it's not mandatory, it's not for everyone, and there's no one approach that will suit every person who's taking opioids for pain.
Thanks, Ali. And I was glad to hear you say that opioids will still have a big place in pain management, because I have the feeling that aside from really acute pain and palliative care, there are some who believe that opioids essentially should have little or no place in pain management nowadays. I thought maybe could we pass on to that, maybe Sharon next to make any additional comments or ask any questions?
So I guess my comment is that, you know, as part of the guideline group, I was impressed, you know, a gazillion times about how thorough the process and rigorous the process was, and the expertise and experiences of everyone involved in the formation of these guidelines. In particular, having a consumer representative there, a person who experienced chronic pain, you know, and I'm very proud to be involved in it. And I think it's really important tonight that we could highlight that you don't, these guidelines involve considering the guidelines, considering the situation and applying your clinical judgment.
That's music to one's ears. Simon, would you like to comment?
Yeah, so Richard, your question is about legacy patients, and I think the truth is that some people will never be able to get off opiates, and I think some people will fall into the grey area where there's repeated acute episodes, or there's palliative care. They might be, we don't know whether they've got a year to live or maybe 2 years to live, but there might well be cancer-related pain as well. There might be dependency, and they might not be. Most people who will be identified as with something like ScriptSafe, for example, won't be needing a formal opiate agonist therapy program, but most people will need some sort of boundary. So my opinion is, with the legacy patients, is that we have to introduce the sort of things that they should have in the first place, which is the great pain care. And we also need to introduce boundaries and good opiate care, which is often based on what we're familiar with in opiate agonist therapy, and I would call it harm management. With the idea about good pain care, Ali quite correctly said the therapeutic goal is multidisciplinary care. Multidisciplinary care has been shown to be much better than treatment as usual, which is GP care. But in my opinion, multidisciplinary care is what is called for when you haven't got a really great GP. And so that's why I think multimodal has been kept with this program, because we need to make sure that people are getting a very holistic and multifaceted approach to many aspects, physical, mental, spiritual, just like we do in palliative care for their great pain care. And we need to be moving away from initiating and continuing in a liberal fashion their opiates.
Thanks, Simon. Now I'm seeing some typed questions, but I think next in order might be to ask Hester to comment on where we've got so far.
Yeah, look, I had a question, Ali, in terms of the implementation. So, and I am, I did see a question come up from Frank McLeod, similar to what I was thinking. Guidelines, fantastic, but how often are they available in a user-friendly way, particularly for GPs? So I'm just interested, Ailey, in terms of, are there plans to look at how, I mean, I know you did put that up, but how are you going to ensure that these very detailed guidelines are available to GPs in a very easy to manage way? And how, on top of that, how can you ensure that our regulatory services who are pushing a hard line acknowledge these and work more collaboratively? So it's really, because what I'm hearing from my GP colleagues is this, as Richard said, this real fear around continuing to prescribe, really worried about getting into trouble. All of us know people that have gotten into trouble with regulatory services, and so there is. So I'm really interested in how we can ensure that there's good, sensible implementation that's able to be used.
So two great comments, and I note that David Outridge has also addressed what's been the response to the health district integrated pain services, or whatever those pain services are in the public sector, to the growing concerns about blanket deprescribing recommendations. So I don't know who's the best person to ask to answer those two questions: how best to make sure that GPs, and indeed why not all doctors, are aware in simple format now that NPS isn't available for us. And the second question, what will be the regulatory or the public sector response to this? Would anybody care to comment? I'm seeing Deborah Zardor there, and I'm thinking I should ask Deborah. Deborah, if you're speaking, you're still on mute.
Hello, can you hear me now?
Yes.
Yeah, sure. Look, I think there are a number of levels of what we're calling regulatory responses now. And I think where a lot of the concern around regulatory is coming in is the SafeScript responses here. Is this what I'm picking up, is that a number of prescribers have been receiving messages, dots, flashes, exclamation marks on SafeScript, alerting them that your patient, whatever is prescribing more than the recommended maximum, etc., or is picking up from multiple prescribers and so on. There's the actual formal regulatory process in which applications are required to have authority to prescribe certain opioids to certain patients. And I need to remind everyone, as you know, that the whole medicines, poison therapeutic goods regulations are out for consultation now. This is being reviewed. However, there's another level at which PRU is involved, and that is also, I think, causing some problems in some of the requirements around the permission that the authority that PI gives to individual cases, and that this can seem variable and can differ from person to person. And that, and the application, the process now, which will be in place for at least another 12 or 18 months, because the new regulations, the Act, don't actually come into force for another year, is not necessarily prescribed in regulations. Some of that are policies that PRU internally refers to guide their assessments of applications, and that can be changed. That is a process that needs more dialogue with PRU around this. So look, I think it's not prescriptive, except for where we must have authorities, such as prescribing methadone buprenorphine to opioid-dependent people. But some of it is interpretation of it, and there's a good deal more work that needs to be done. And we're very aware in the ministry of the problems, particularly around opioid approvals for chronic pain patients, and we're working much more closely with PRU to improve the dialogue, review the complaints that are coming in, and to try and liberalise this space a bit more. But some of this is professional decision making, and PRU probably needs to work with opinion leaders in both pain and addictions to come up with better guidelines by which they can judge these applications. It is a very complex space and area here. There are some improvements that are being flagged in the new regulations. As we all know, that any application for OAT is going to be notification only. It's no longer going to require an approval. They are looking at introducing a number of exemptions from when authority or in time a notification will be required. So I think I would urge anyone who's interested in this space to get a copy of the current draft regulations. It's open for consultation at the end of the year. We did do, the centre did do a consultation of all addiction medicine specialists and nurse practitioners to get feedback on the new regulations. We got a lot of comments around the difficulties prescribing opioids to paying patients and so on. And the feedback was very diverse. Addiction medicine specialists are not a united body, and we struggle to summarise clear viewpoints from the survey of addiction medicine specialists around the new regulations. And so we compiled a report. We sent that in to a legal and regulatory, which is taking the lead for drafting the new regulations. And some of that advice has been taken on board, not all. And I think part of it was because for X number of addiction med specialists who wanted no exemptions or exemptions, an equal number would say, yes, we need greater control. So it's a very difficult space here, coming out with clear lines. But I'm highly sensitive to some of the probably absurd sort of application process that go on at the moment with simply trying to get authority, such as the requirement, to have to get a second pain specialist opinion to continue prescribing opioid to a patient very well. And I think those things, though, are just policy. They can be changed.
Deborah, that's a great response. Maybe you can let us know in the chat how we can access that draft document to comment on it. That would be very helpful. I noticed that Simon's had his hand up, so I'll ask him next and then get to a couple of comments. Leona's next. Simon, what did you want to say, if you're still with us?
I wanted to speak on how we're going to get this implemented in general practice, which is more where most of this action is going. And I think we have to have some degree of coordination between federal, state and professional bodies. And something like the upcoming proposed New South Wales drug summit's a good start. But I've got a number of ideas in no particular order, but electronic health records, we should be having pop-ups about opiates, opiate milliequivalence tables, some suggestions. We could be looking at the medical benefits schedule so that rather than treating throughput, we're actually looking at the complexity of care and the time and emotional demands that it puts on a clinician to change the inertia of continued prescribing. We need to see better support for multidisciplinary care, which has got so much to offer, even though I've just said what I said about multimodal care. We need to resurrect the NPS or the equivalent of, so we do have academic detailing. We've had so much commercial education in this space, and we need non-commercial education, and we need brief education that's accessible for doctors in their usual fashion. We need the medical board, this is talking to Deborah, we need the medical board to, rather than looking at punishing bad doctors who are, dishonest, duped, or deluded, or just past their use-by date, we need those doctors who are liberal prescribers to actually get help, because they might not be able to cope. They might find the emotional conflict just too much. And so rather than having punishments, those people need support and encouragement, and then they continue to give much better care. We need to see buprenorphine taken off the indication for dependency only and put on an indication for pain. I think this whole debate, if we had buprenorphine as a pain treatment, all our individual and public health concerns would be going away. We wouldn't have the issues about overdose. We wouldn't have the issues about diversion, people doubling up when they're stressed or their partner leaves them, all that stuff. And it's a really good analgesic. and we don't seem to see the hyperalgesia.
Simon, I'm going to have to interrupt because we've got Jenny's case to present. They're all great points. You've also answered one of our David's on buprenorphine there. Thanks for that. But just with an eye on the clock, can we move on to Jenny's and then any further questions at the end? Jenny, your case.
Yeah, thanks, Richard. I'll just share screen and then. Okay, great. Everyone can see that? All okay?
Yep.
Okay, great. So I'm a GP and I'm a part of a team at Southwest Drug Health Services. I work with 2 wonderful CNCs, and our aim is to support GPs in the local Southwest region as much as we can. And this case presents some typical dilemmas from general practice and demonstrates some integrated care between general practice and drug health services. So Joshua is a 27-year-old man who described having a good life, which drastically changed when he was 19 years of age. He was the driver of a car that ran into a pole at 120 k's an hour, and there were no other occupants in the car. His injuries were solely musculoskeletal and multiple, and have resulted in chronic pain since then. And his first point of contact with our service was 4 years post motor vehicle accident, when his GP rang our Southwest Sydney General Practice helpline. Joshua's injuries were to his low back, ribs, legs, ankles, and there's no future orthopaedic involvement suggested, and the worst of his pain is in his low back. And apart from a small amount of physio, there'd been no treatment for his chronic pain. The GP had referred him to pain clinics on 3 occasions, and Joshua hadn't gone. He said he didn't believe it would make any difference, and he was also worried about doctors interfering with the medication that he was on. His substance use only involved less than 1 joint of cannabis a month, nothing else. And at the time of the GP's call, Joshua was living at home with his mother and father and brother. They were all very good support for him. And he self-described as unmotivated and stayed in bed a lot of the day watching videos. He had a small circle of friends he went out with occasionally. He had worked briefly in a cleaning business, was studying to be an electrician before his accident, and he had short periods of work since the MVA, but largely interrupted by pain and poor concentration. He described his mood as always low since the motor vehicle accident, and the GP felt, though, there was no formal diagnosis of depression. He had no problem sleeping. He'd put on 3 kilos since the accident. He felt life was not worth living for the first few months after his accident, but more recently was talking about future plans, such as getting a job and online dating. I don't think there'd been much exploration of his mental health in terms of presence of anxiety disorders, including PTSD, at that point we got that first phone call. In his GP care, there were 2 GPs involved in the first 3 years post-MVA. Then Joshua changed surgeries in 2018, and GP 3 treated Joshua up to early 2020. Then Joshua began to see GP 4 at the same surgery from early 2020 because GP 3 said he wasn't going to prescribe any further opioid medications to any of his patients anymore. And Joshua's medications, he was commenced on oxycodone very soon after his motor vehicle accident, and he's been on it ever since. GP3 had been prescribing short-acting oxycodone 30 milligrams 3 times a day and pregabalin 300 BD, and then GP4 had tapered that down to short-acting oxycodone 10 milligrams twice a day with continuation of the same pregabalin. And that taper, which had gone from a total daily dose of 90 milligrams down to 20 milligrams, had gone over about 11 months, and there had been no opioid withdrawal discomfort. And during that taper, there were no signs of opioid dependence. So you might wonder, why did the GP call, given that Joshua had been tapered what seemed to be successfully down to endo and 10 milligrams twice a day? So at that point, the different goals of the GP had and that the patient had became quite apparent. The GP wanted to taper Joshua down to 0, felt that was the right thing to do. And Joshua wanted to trial an increase in his dose of endo back up to 10 milligrams 3 times a day. And Joshua wondered if that would decrease his pain, allow him to go back to the gym. So it was just in that final tapering down to 0 that there was some increased friction, I guess, between Joshua and his GP. So Joshua had felt his pain had become a little bit, but not hugely worse during that taper from 90 down to 20. And in terms of gauging activity and life involvement, there was no formal monitoring with a PEG tool, but nothing much had changed. So he was still pretty sedentary during the day and self-described his mood as low. So what did we do at that point? There was a discussion about the pain management being very underdone. So we thought we'd use some case conferencing MBS item numbers to deliver some longer interventions from within the general practice setting, at which point I'm just going to slip over to the next slide to sum up the frameworks that we used. There's that word biopsychosocial, you see it all the time. So we had some discussions about what those approaches are. And the GP introduced the PEG tool and took on monitoring, not just the pain, but enjoyment of life and activity levels as well. And we asked Joshua to choose from a smorgasbord of active treatments. But in order to do this, we had to first explain to Joshua why things like thoughts and feelings and treating stress and doing exercise and engaging in things that give you a sense of purpose can dial the level of pain down. So we had to provide a rationale for active treatment approaches that would be accepted by Joshua. And the link I've got on that slide, it just provides an example of such an explanation. It's actually in the form of a 7-minute video, which comes from the New South Wales ACI Pain Network. And the GP sat and watched that video with Joshua in his consult room, and Joshua found that a sort of a good way of understanding why it is that non-pharmacological approaches have got some place to play. So we held on the same dose of oxycodone and pregabalin. We talked about potential problems with opioids, including dependence, and the GP outlined the prescribing structures he would put in place, and they are listed on that slide. And 2 months later, things were going reasonably well. Joshua started going to the pool. He had a new girlfriend and he was out and about quite a bit. He was still on 10 milligrams twice a day, and GP4 said he was happy just to continue management without any further support from Drug Health. So fast forward 2.5 years later, and we had a call from GP4 again. So GP4 had taken leave earlier in the year, and Joshua had gone back to GP3 at the same surgery, and his endone dose was increased to 10 milligrams 5 times a day, and he'd started to come in early for some repeat scripts. The pregabalin was prescribed in the total daily dose of 600 milligrams, but Joshua was taking 900 milligrams total daily a day. And Joshua had returned to GP4 when that GP came back from leave, and Joshua told him that he'd ended a relationship recently with his partner. He was embarrassed about his use of opioid medication, and he self-described as, it was his words, out of control. And he told GP4 he was also taking 60 milligrams of his father's endone daily, and his father was prescribed that for management of pain from an end-stage malignancy. There was no other substance use going on, and SafeScript showed there were no other GPs prescribing any monitored medications. So in summary, Joshua was taking endone 110 milligrams daily, which he usually took as 5 doses during the day, and pregabalin 300 milligrams 3 times a day. And his GP had already discussed buprenorphine treatment with Joshua, but Joshua wanted to stay on his current oxycodone. And Joshua wasn't particularly interested in engaging with medical consults at Drug Health, but he took an option of an admission into our withdrawal unit, which was for stabilisation of his opioid doses and commencement of structured tapering, and the hope was that Joshua might change his mind and accept buprenorphine treatment. So Joshua stayed for 4 days, but he continued to decline any treatment with opioid agonist treatment. So he was discharged on OxyContin modified release, 40 milligrams twice a day, endone 5 milligrams 6 hourly with a maximum of 4 tablets a day, and pregabalin total daily dose 600 a day. And we set up daily stage supply with one pharmacy, contract with his GP, SafeScript monitoring, and an addiction clinic review 4 days later. And GP4 applied to PRU for an authority and obtained a 6-month authority to continue to prescribe oxycodone under conditions that it would be tapered down to 0. Following discharge, Joshua continued to see his GP regularly, but apart from one telephone consult with one of our specialists, he declined to engage with any further clinicians other than his GP. So the GP organised some further assessments of his mental health, and we provided advice over the telephone regarding tapering. And there was a reduction, a 5 milligram drop in the MR oxycodone dose. 2 weeks later, a further 5 milligram reduction. Joshua was physiologically comfortable with that, but he really hated going to the pharmacy every day. However, he was going. And the plan is for ongoing slow tapering, aiming to avoid discomfort from opioid withdrawal. That tight structure for prescribing at the moment, including daily stage supply, is staying in place. And ongoing telephone support is what we're giving the GP. Harm minimisation will be continued and encouragement to commence buprenorphine. So I just thought that this case probably touches on a lot of the points, excellent points that everybody else has been making about this. So this case brings up the question of how to manage prescription opioid dependence when patients do not want opioid agonist treatment. And we know that deprescribing in this scenario of opioid dependence is likely to fail. I think it was also an illustration of that when we're deprescribing, we need to be very confident in talking to patients about active, non-pharmacological treatment approaches to chronic pain. And as part of this, we need to provide an explanation to our patients as to why those approaches work. And I've personally found that getting to that explanation requires quite a bit of thought and quite a bit of practice. And we can also set a lot of structure around deprescribing, but of course we can't monitor for non-prescribed opioid use. But we can see in this case the deprescribing it's holding the patient whilst there's ongoing work with motivational enhancement with this aim to provide buprenorphine treatment. And I think this also illustrates the kind of challenges that arise when GPs have different approaches to prescribing drugs of dependence. And that can be within the one practice or between different practices. Practice policies can be helpful in ensuring a uniform and safe approach to prescribing drugs of dependence, but of course that also depends on what the practice policy is. So GPs can refer to guidelines such as those we've discussed tonight, and there are RACGP documents in this area, or at least seeking advice from AOD clinicians or from the RACGP special interest group. So all of these sorts of things can be a good guide. And if GPs are being asked to manage this kind of really challenging scenario, this GP fed back that with this kind of challenging medicine, he said, look, I've only got the confidence to proceed as long as I have at the very least got telephone advice from the specialist service available so that I can have some confidence that what I'm doing is providing reasonable care for the patient. So I'll just stop sharing at that point.
Thanks, Jenny.
Okay.
Great. It's a lot of really important points. Thought I might just ask Hester for a quick comment. We have some comments in the chat I'll come to, but Hester, what's your first reaction to that case?
I think this is the sort of patient that we very, very commonly see in the general practice setting and are trying to manage with very limited support. So people have pointed out that there aren't, particularly in rural regional areas, and in metro areas as well, it's very hard to access pain management clinics. This is a group of people who don't see themselves as having an addiction, so they don't want to go to drug and alcohol services. And it is really complex. And we're asking GPs who are excellent at managing chronic disease in the community setting, but to manage this on their own without support when they're not actually being paid well enough to do it. So, you know, for us that are working in the specialist setting, we really do need to be shifting this balance and really supporting, as Jenny's team has done, you know, to really support this GP and to be available with that ongoing telephone support. And I think, you know, I do feel that in the specialist setting we have let GPs down and they've been struggling. And this is certainly what I'm seeing in my PhD that looks at this issue, a huge amount of anxiety and fear and concern around the risk and what this means for their patient, and for their patient's well-being, and also for their own well-being and their professional standing as well. So we really do need to think about, and this has been raised in the chat as well, that issue around, for this person who's developed an opioid use disorder or an opioid dependency, as well as chronic pain, how do we manage both these conditions adequately?
Yeah, and not in a binary fashion as
exactly
right there. And I'm thinking here about the amount, you know, the sheer extent of the support that Jenny's services provided to this doctor, and in the absence of that service, how any such support would be provided. I cannot imagine public pain service offering anything equivalent. I don't know who else would. There was a comment there of perhaps the possibility of engaging a psychologist for formal motivational interviewing and better access referral by Medicare. But that's still left to the GP somehow to pull it together, isn't it?
And look, and the other thing with better access is it's limited sessions. And there aren't that many psychologists that are actually really confident in terms of supporting people with chronic pain. You know, and so it's a huge area. You know, that there's good evidence for those psychological strategies and for that, as Simon was saying, that multimodal care, but very little access to it.
And physiotherapy likewise.
Yeah, totally.
It's all, you know, often people who are asked, have you had physiotherapy? I've done all of that, dismissively, and because they know they've got a series of exercises they're supposed to do when they go home. And after all, that's then up to them. And I think that's part of the problem, is that if you're in the circus ring with the circus master whipping you on, continuing the physiotherapy under supervision in a supportive environment might be more likely to happen. Sharon, could you make a comment at this point?
Hello, Richard. Sorry, I'm Riazul Hassan. I'm one of the pain medicine fellow from Newcastle John Hunter Hospital, and also I work with Adrian as his trainee in addiction medicine. So I'm doing the both training. So it's a very nice case presentation. You can see classical case with both the chronic pain and the addiction. In John Hunter Hospital, we've got a monthly combined pain and drug and alcohol clinic. So those sort of the patient who has got both issue with the pain and addiction, we see this patient in this clinic. I'm not sure whether there's any other public service that they've got this type of clinic. I think that's going to be very useful for the GP if they've got any local public service to manage both the pain and addiction.
Southeast Sydney certainly does, or has done, have an integrated service like that. We haven't ever managed that at Liverpool, I must say. I'm not sure how much access that gives to GPs, though. I did want to ask Sharon what your take was on the case.
Sorry, what my take on the case? Meaning...
on case, yeah. You take home thoughts. How did it strike you?
The case that was presented by Jenny. Yep. Yeah. No, I think it's probably not uncommon, really. And a lot of the patients I see in the opioid agonist treatment have been people that, you know, had some sort of injury and have progressed. Some of them have progressed to illicit opioids, but a lot of them more prescribed. And in my setting also, I've seen the use of depo-buprenorphine quite helpful for some of these patients, in particular Sublocade. So that's sort of my experience.
There might be an increasing range of possibilities for buprenorphine in such cases if you can get around the addiction treatment stigma.
Yeah.
Simon, your comment, I interrupted you when you were about to make the excellent remark that maybe this should become compulsory in our CPD to have training in such matters. If we're doing compulsory training for CPR, then why not for deprescribing? Did you have any other further comment?
Yeah, just about that last case. I think if we understood, we need to get away from the morality of prescribing and deprescribing, go to the science, and we need to understand that the opiate system, through which does many things in our body apart from just analgesia and feeling good and feeling high, is all about is a lot to do with relationships and families and partners and tribes and how we connect to other people. And if we swap that endogenous opioid system with exogenous opioids like Oxycontin, then it's no wonder that people behave in a different psychosocial fashion. They think, feel, behave, and relate differently. And these are the features that we see and we call addiction. So we shouldn't be surprised at all when we see effects on the psychosocial effects from our prescribing. This is normal, and we shouldn't be perturbed about it. We just need to put boundaries, discuss it, and try to stop harming our patients, like this patient.
Yeah, so there's some excellent comments here. Prince of Wales indeed doing something that provides access for GPs to some specialist advice. I think perhaps penultimately, if we can go back to Susie and Ailey for any closing thoughts from you.
Well, I just typed a really long thing in the chat, just talking about a clinical observership situation that I had in Toronto, just talking about the framing of buprenorphine. And, we know that there are these patients on very high doses of opioids who are at risk. And the fact that we have to kind of convince them that they have to go onto an addiction treatment, I think that's a huge barrier. And it was just so refreshing seeing it offered there as just, look, this is a safer opioid. You're less likely to have an overdose or stop breathing. And just how much easier it was to offer patients those alternatives when it wasn't in this framing. So I think that's, a lot of people have commented on that. That was just a salient point that came up to me. And I do think the fact that the guidelines really kind of highlighted not just when to consider deprescribing, but when not to, kind of really just endorsed that it's going to be different for everyone and there's lots of considerations.
Yeah, and Jenny made that point.
Yeah. So I'll hand over to Ailey for the final word.
My final word was just going to be in regard to the dissemination and implementation. And I think that's a whole nother challenge. But hopefully that's the next steps, and my postdoc will be working on that. But I think there's also some great information in the chat from Mark about health pathways and things. And I think really working with existing systems will be integral to disseminating and implementing the work. So would love to be involved with if anyone has ideas and wants to partner on the next steps, please reach out to me.
Okay, so some thumbs up around the room there. I will shortly bring this to a close. Mention very briefly in passing that we did talk about the PRU and its job in providing authorities and working through all of that. And I want to do a shout out, as they say, for the hardworking staff at PRU, because they really they do have to work very hard. We're often making incessant demands on them, and it's a complex area. And this would be my opportunity to say that this should not be unappreciated, should not go unremarked. So if there are no further questions, I'll thank everybody for participating. A wonderful case, wonderful presentation. And I wonder whether, Dan, you can leave the chat open for just a bit longer in case people want a few more minutes to peruse it.
Yeah, no, I'm more than happy to. I'll stay online for a few more minutes if anyone wants to provide any further comments. But we have hit the 8:30 mark, so I think for the most part we can wrap up. Thank you everyone for such wonderful discussion. I hope you all really enjoyed this Sydney Addiction Seminar session. I did just want to briefly remind everyone, if I can pop it up again, we do also, of course, record our sessions, so you can also access previous recordings, and very shortly we'll be able to access this recording as well. And everyone that has attended, we'll make sure that we send out a certificate with this link. I've also put in the chat the link to that consultation that Deb Zardor mentioned. I'll make sure we include that in the email as well as the deprescribing guidelines and anything else. But otherwise, feel free to sign off and have a wonderful evening.